Welcome to the image analysis for the shoulder. We will review the common projections of the AP internal, external, and neutral projection. We will also review the gray sheet and the Y view. We will also review common improper positioning errors and how to take corrective action. Image analysis guidelines for the AP projection of the shoulder in all views states that the scapular body demonstrates minimal transverse foreshortening and half of the superior scapular body is visualized without thorax superimposition. The clavicle should be demonstrated with minimal longitudinal foreshortening and with the medial clavicular end positioned next to the lateral edge of the vertebral column. The glenoid cavity is partially demonstrated with the humeral head superimposing it. The scapular body is demonstrated without longitudinal foreshortening. The mid-clavicle superimposes the superior scapular angle. The humerus is demonstrated without abduction. In a neutral positioned AP shoulder projection, the greater tubercle is partially seen in profile laterally, and the humeral head is partially seen in profile medially. In a externally rotated humerus AP shoulder projection, the greater tubercle is seen in profile laterally, and the humeral head is in profile medially. Should always put an indicator marker on your images so that the radiologist knows you took this projection in external or internal rotation. Lastly, for the AP shoulder internal rotation projection, the lesser tubercle is seen in profile medially and the humeral head is superimposed by the greater tubercle. For all AP shoulder projections, the superior scapular body is at the center of the exposure field and the glenohumeral joint, clavicle, proximal third of the humerus, and superior scapula are all to be included within the exposure field. Here are those guidelines for your review. So let's discuss the effects of mid-coronal plane tilt in the AP projection of the shoulder. When the upper mid-coronal plane is tilted anteriorly, the scapular body will exhibit longitudinal foreshortening. This means that the scapula will appear compressed along its length, altering its normal anatomical representation in the image. Additionally, the superior scapular angle will be positioned superior to the mid-clavicle. This misalignment can affect diagnostic accuracy and requires repositioning of the patient to obtain an optimal radiograph. Conversely, when the upper mid-coronal plane is tilted posteriorly, similar longitudinal foreshortening of the scapular body occurs. However, in this case, the superior scapular angle is visualized inferior to the mid-clavicle. This deviation can result in improper anatomic visualization, potentially impacting the image interpretation and clinical decision-making. Therefore, proper alignment of the mid-coronal plane is essential for accurate AP shoulder imaging. So now let's move on to how torso rotation affects radiographic projections of the AP shoulder. When the torso is rotated towards the affected shoulder, there are several key changes that occur in the radiographic image. The medial end of the clavicle appears rotated away from the lateral edge of the vertebral column. Additionally, there is increased superimposition of the thoracic structures and the scapular body, leading to a less distinct visualization of the scapula. The clavicle also appears more foreshortened, and the visibility of the glenoid cavity is reduced. This positioning may obscure some important anatomic structures and affect your diagnostic accuracy. On the other hand, when the torso is rotated away from the affected shoulder, the medial clavicular end shifts to superimpose the vertebral column. In this position, there is decreased superimposition of the thoracic structures and the scapular body, providing a clearer view of the scapula. The clavicle will appear less foreshortened, and the visualization of the glenoid cavity increases. In summary, torso rotation significantly impacts AP shoulder projections. It's essential to ensure that the patient's mid-coronal plane is parallel with the IR. Go ahead and analyze this first AP shoulder practice analysis. Disregard the positioning for a internal or external view. We're looking for more rotation and a body tilt or plane tilt. So let's look at this first practice analysis together. When looking at a AP shoulder projection, we want to make sure that we have the appropriate anatomic structures on the image, in which we have our entire shoulder, including the medial clavicular end, and the 1/3 of the humerus. Next, you want to determine whether we have any rotation or plane tilt. When identifying rotation, we want to look at the medial clavicular end and determine whether it is in alignment with the vertebral column. In this case, it is, and therefore we have no rotation. Next, we want to look at the superior angle of the scapula, and in this case, it is not aligned with the mid clavicle. So this, the position is actually superior to the clavicle, which should indicate to you that the mid-coronal plane was tilted anteriorly. We need to repeat this image and align the mid-coronal plane parallel with the IR. Again, go ahead and analyze this image with disregard to the humerus positioning. Let's analyze this projection and the positioning of this AP shoulder practice analysis. When looking at this image, I can tell from right off the bat there is some rotation. I am looking at the clavicles. One is foreshortened and one is super elongated to the point it is crossing the vertebral column. This patient is rotated towards the affected shoulder. In addition, the lateral border of the scapula is entirely superimposed by the thorax, so that should be another indicator of some rotation. In order to correct this patient's positioning, we need to rotate that patient away from that affected shoulder until their mid-coronal plane is parallel with the IR. Go ahead and review this last practice analysis and answer the following question. So let's review this last practice analysis of the AP shoulder together. Again, we're going to look for rotation and coronal plane tilt. First, we're going to look at the medial clavicular end to determine if there's any rotation, and it is superimposing over the vertebral column. This should let you know that the patient is rotated towards the unaffected shoulder. Also, we want to look for plane tilting. Okay, the scapular body is drawn away from the thorax more than in a true AP projection, so it is transversely foreshortened. In order to correct this, we're going to have to get that coronal plane parallel with the IR again. Another key anatomic misalignment to speak about is looking and identifying the superior scapular angle. It is positioned above the mid-clavicle. There is some anterior mid-coronal plane tilt here. In order to correct this imaging, we need to rotate that patient towards the affected shoulder into an AP projection and assure that the mid-coronal plane is aligned parallel with the IR. Now let's move on to the image analysis of the AP oblique projection Gracie method. Image analysis guidelines for the AP oblique projection Gracie method state that the glenoid cavity is demonstrated in profile and the glenohumeral joint space is open. 1/3 of the coracoid process is superimposing the humeral head. The glenoid cavity is shown without thorax superimposition. The clavicle is longitudinally foreshortened and is horizontally situated. If the patient is in a recumbent position, then the glenoid cavity is situated slightly superior and the clavicle is foreshortened, aligned vertically and superimposing the scapular neck. I have an image of that which I will show you. In addition, the superior margin of the coracoid process is aligned with the superior margin of the glenoid cavity. The glenohumeral joint should be at the center of the exposure field. The glenoid cavity, humeral head, coracoid, and acromion processes and lateral clavicular end are all to be included within the exposure field. Here are those image analysis guidelines. Here is an image of an accurately positioned recumbent AP oblique shoulder projection. In this projection, you can see that the clavicle is aligned vertically and is foreshortened, superimposing the scapular neck there, right? And then the glenoid cavity is situated slightly superiorly. Just take note that positioning does change from upright to recumbent. So now let's discuss the effects of excessive and insufficient torso and shoulder rotation in the AP oblique projection. When the torso and shoulder are rotated more than the required amount, significant changes occur in the radiographic image. The glenohumeral joint space becomes closed, limiting the visibility of the joint structures. Additionally, more than 1/3 of the lateral coracoid process becomes superimposed over the humeral head. Conversely, if the torso and shoulder are rotated less than the required amount, similar complications occur. The glenohumeral joint space remains closed, but in this case, less than 1/3 of the coracoid process is superimposed over the humeral head. Excessive and insufficient torso and shoulder rotation can lead to improper visualization of the joint, therefore requiring a repeat radiograph. Go ahead and analyze this AP projection of the gray sheet method and answer the following question. So let's take a closer look at this practice analysis together. The first thing we should be looking for is an open glenohumeral joint space, and in this case it is closed. The next an anatomic alignment I'm going to look for is where is the tip of the coracoid process. It is superimposing less than that 1/3 of the humeral head. This should indicate to you that there is insufficient patient obliquity. You can also look at the positioning of the clavicle as it shows minimal foreshortening to help you identify rotation errors. In addition, there is a little bit of mid-coronal plane tilt posterior. If you take a look, the superior margin of the coracoid process is situated above the glenoid cavity superior margin, which again should indicate to you that there's a little bit of plane tilt posterior. It should be aligned with the superior margin of the glenoid cavity, not above it. In order to correct this, these positioning errors, we need to increase that patient obliquity and align the mid-coronal plane parallel to the IR. Go ahead and review this AP oblique practice analysis and answer the following question. Let's review this AP oblique shoulder practice analysis together. For this image, we are looking for a glenohumeral joint space to be open. Again, it is closed, so therefore we have a positioning error. First, we're going to look for the position of the coracoid process. In this case, the coracoid process is superimposed over more than 1/3 of the humeral head here. This should indicate to you that when it becomes a little bit more elongated, the coracoid, or when the clavicle shows excessive foreshortening, that the patient is in excessive obliquity. In order to correct this positioning error, we need to decrease the degree of patient obliquity. Let's move on to the scapular Y projection. Image analysis guidelines for the PA oblique scapular Y projection state that the scapular body is in a lateral projection with superimposed lateral and vertebral scapular borders. Scapular structures form a Y with the scapular body as the leg and the acromion and coracoid processes as the arms. The glenoid cavity is demonstrated on end at the converging point of the arms and leg of the Y. If there is no injury in the patient, then the glenoid cavity and the humeral head and scapular body and the humeral shaft will all be superimposed. However, if there's shoulder dislocation, then the glenoid cavity does not superimpose the humeral head. In the case that there is a proximal humerus fracture, the glenoid cavity will superimpose the humeral head, but the scapular body does not necessarily superimpose the humeral shaft. In any case, the scapula should be demonstrated without longitudinal foreshortening. The clavicle and superior scapular angle are visualized at the same transverse level. The mid-scapular body is at the center of the exposure field. The scapula, including the inferior and superior angles, the coracoid anacromion processes, and the proximal humerus are all included within the exposure field. Here are those image analysis guidelines for your review. So let's talk about how we identify the scapular borders when a true lateral is not obtained. The lateral border is thick with two cortical lines that are separated approximately by a 1/4 inch, whereas the cortical outline of the vertebral border demonstrates a single thin line, as you can see here. So let's discuss the effects of excessive and insufficient torso and shoulder obliquity in a Y view. When excessive obliquity is present, the lateral border of the scapula is either superimposed by the thorax or positioned closer to the thorax than the vertebral border. This misalignment affects the appearance of the glenoid cavity, which rotates in the same direction as the lateral border. On the other hand, when obliquity is insufficient for a Y view, the vertebral border of the scapula superimposes the thorax or appears closer to the thorax than the lateral border. Similar to excessive obliquity, the glenoid cavity will follow the direction of the lateral border, affecting its alignment in the projection. This can impact the clarity and detail needed for proper evaluation of the shoulder. Go ahead and review this practice analysis and answer the following question. In this first practice analysis, we want to identify if we have our anatomic structures and are we positioned appropriately. In this case, we have the anatomic structures. However, the lateral and medial vertebral borders are not scapular borders, sorry, are not superimposed. In this case, the vertebral border is adjacent to the ribs, which should indicate to you that the patient is insufficiently rotated. In order to take corrective action, we need to increase patient obliquity. Go ahead and review this next practice analysis and answer the following question. So in reviewing this practice analysis, we want to determine whether we have all the anatomy necessary, and in this case we do. We have plus some, so we definitely have a little bit of two-part IR issues going on here, and we need to also collimate. This looks like almost a 14 by 17 field of view, so please, please, please don't let me see you doing this. But now let's take a look and see if our positioning is appropriate. In looking at the medial and lateral borders of the scapula here, they appear to be superimposed. However, we do have some plane tilting here. You can identify this by looking at the superior angle of the scapula. If it is not in line with that clavicle and is projected above, then the patient is leaning more towards the IR. So there is some anterior tilt here. In order to correct this, we need to straighten up that mid-coronal plane until it's aligned parallel with the IR. Otherwise, the scapular body will be foreshortened. And again, the same rules apply with tilt in the AP as in the Y projection. If the superior angle of the scapula is projected below the clavicle, mid-clavicle, then you have some posterior tilt. However, typically anterior tilt is seen more often than posterior in the Y view. Go ahead and review this last practice analysis and answer the following question. Let's review this practice analysis together. First, you want to identify if all our anatomic structures are present. Yes, they are. However, are we positioned appropriately? First, we want to identify whether or not the lateral and vertebral scapular borders are superimposed. In this case, the lateral border is positioned closer to the thorax. The glenoid cavity is visible but not seen on end. It's closer to the thorax. This should indicate to you that the patient was excessively rotated. We're going to need to decrease that patient obliquity to get a true lateral projection of the scapular body. This concludes our image analysis of the shoulder. If you have any questions, please feel free to reach out to me at clinic or via email. Thank you.